This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara. Today we're looking at a fascinating new study from the journal Archivos Argentinos de Pediatria, published in 2026. It's titled Open Fetal Surgery for Spina Bifida in a Tertiary Hospital in Argentina, Short and Medium-Term Outcomes.
This is a crucial topic for our listeners, especially the residents and fellows tuning in. As we know, spina bifida, specifically myelomeningocele, or MNC, is one of the most severe congenital malformations we deal with. The associated neonatal morbidity and long-term disability can be devastating. For years, the gold standard for many has been the MOMS trial, the Management of Myelomeningocele study. But seeing how those results translate into real-world, international tertiary centers is where the real learning happens.
Exactly. This study is a retrospective observational analysis of 102 consecutive cases operated on between 2015 and 2023 at a single center in Argentina. What's interesting here is that they've been using a modified open surgical technique for intrauterine repair.
102 cases is a significant cohort for a single center study. It provides a robust look at the learning curve and the efficacy of their multidisciplinary approach. Alara, let's dive into the patient population and the timing. When were these interventions taking place?
The team was operating at a mean gestational age of 26.1 weeks. That's a very specific window designed to mitigate the two-hit hypothesis of MMC, where the primary neurological defect is exacerbated by prolonged exposure to amniotic fluid and mechanical trauma in utero.
Right. The goal is to arrest that damage early. Now, as neurosurgeons, we're always concerned about the trade-offs. Fetal surgery isn't just about the fetus, it's about maternal safety as well. What did the study find regarding the safety profile?
That was a major highlight. The authors reported that maternal and neonatal complication rates were actually similar to or even lower than those reported in the original MOM study. They described a favorable maternal-fetal safety profile, which really speaks to the refinement of their modified surgical technique and the strength of their multidisciplinary team.
That's an important point for the residents listening. Neurosurgery in the fetal space is never a solo act. It requires seamless coordination with obstetrics, neonatology, and anesthesia. But let's get into the neurosurgical outcomes. One of our primary markers for success in MMC repair is the subsequent need for hydrocephalus treatment. How did they fare?
This is perhaps the most striking part of the data. The need for ventriculoperitoneal shunting at 12 months was only 23.8%.
23.8%? That is remarkably low. If you compare that to the historical rates of postnatal repair, where we often see shunt rates upwards of 80%, or even the MOMS trial results, this confirms that intrauterine intervention significantly alters the natural history of hydrocephalus in these patients. It suggests that reversing the hindbrain herniation in utero, the Chiari-2 malformation, really does improve CSF flow dynamics.
Absolutely. And the benefits extended into the medium-term follow-up as well. They looked at functional outcomes, specifically the ability to walk. At 30 months of age, 84.8% of the children in this study were walking, either with or without orthopedic devices.
That is a powerful statistic to share with parents during prenatal counseling. To be able to say that at nearly 3 years old, over 80% of these children are ambulatory is a testament to the neuroprotective effect of the surgery. It really reinforces the objective of the study, describing not just the perinatal outcomes, but the actual quality of life markers like mobility.
The researchers concluded that their outcomes are comparable to international reference centers. They believe these findings support the continuation and optimization of open fetal repair in experienced centers.
It's a compelling case. They've shown that with a modified technique and a dedicated team, you can achieve results that meet and in some metrics exceed the benchmarks set by the early landmark trials. For our students and residents, the takeaway here is that spinal dysraphism is no longer a wait-and-see diagnosis. It's an intervene and protect scenario.
It also highlights the importance of regional centers of excellence. This study from Argentina shows that high-level neurosurgical care for MMC is thriving and producing excellent data outside of the US and European hubs we usually hear about.
Well said. It's a great example of clinical evidence confirming that we are moving the needle on a once devastating condition. Alara, thanks for breaking this down with me.
My pleasure, Dr. Aris.
And thank you all for listening. Join us next time on the Neurosurgery Hub podcast as we continue to explore the latest research shaping our field. Stay sharp.